Hi, I'm Dr. Mehrdad Ayari, a geriatrician, and today we're going to talk about one of the most symptoms that led to the transfer resident from skilled nursing homes or even assisted living to emergency room. This is about chest pain. Most of the nurses call 911 the minute they hear from the patient that they have chest pain. But do we really need to send all the patients and residents in home care with chest pain to the acute hospital? Be with me, and we're going to talk about this topic today. When we look at the published article, we can notice that many studies have shown that chest pain is one of the most common symptoms that can cause transfer to acute care. One of the most important studies was published in 2012 based on the chart residents transferred from nursing home to the hospital from September 2007 to September 2008. 72 symptoms categories were identified. Some symptoms were identified 10 or more times. But what's particularly interesting is that chest pain was counted in 16% of transfer, highlighted its frequent occurrence. Here, let's learn about some terminology. Angina. It feels like a pressure or squeezing in the chest. The discomfort can also happen in the shoulders, arms, neck, jaw, abdomen, and also even the neck. Women, individuals with diabetes, and younger people may actually present without a classical chest pain, but have symptoms of shortness of breath, weakness, nausea, vomiting, palpitation, or syncope. But technically, angina is what we call angina pectoris, is happen when there's going to be a diminished oxygen to the heart muscle. Another terminology is a pleuritic chest pain. It's the sharp, stabbing, or burning pain in the chest that is actually worsened when you inhale or exhale. It means every time when you breathe, the pain is get worse. It also feel like a dull ache or a catch. Now let's talk about causes of chest pain. It can be heart, cardiac, respiratory. It can be gastrointestinal, like a heartburn. It can be musculoskeletal, which we're going to talk about in more in detail. But also can be psychiatry disorder and can be other cause of the chest pain. There are many things in the body can cause chest pain, and not necessarily all the chest pain is heart related. The scary cause of chest pain is heart related. Acute coronary disease or acute myocardial infarction is one of the most common cause and the scary one. But also aortic dissection, which is a tearing of the aortic valve, pulmonary hypertension, blood clot in the lung circulations, pericarditis, which is inflammation of the sac that is surrounding the heart area, or myocarditis, which is inflammation of the heart muscles, can also cause chest pain. Sometimes valve disease, the people with aortic valve or mitral valve stenosis, they can have a chest pain as well. Patient with acute coronary syndromes, they have angina, which I explained to you. Most of the time angina is a progressive. Means, for example, somebody can have a chest pain, but the chest pain gets more frequent, it gets more longer in duration with even less activity. Like, for example, patient can say, I used to able to walk 2 blocks a day, and after 2 blocks I get chest pain, but now I notice even with like 1 block, half a block, I also get chest pain. This is a typical for angina symptoms, which is a progressive angina symptoms. The symptoms addressed also can be sign of the angina as well. Patient with aortic dissection can have a very acute chest and mainly even back pain that is very sudden, very severe, very sharp, and a kind of like a tearing quality. Pain can actually radiate anywhere in the chest, even through the abdomen. But one of the things about aortic dissection is extremely severe, and especially the patient's feeling on the backside as well. Pericarditis, which is technically inflammation of the sac around the heart, can be secondary to infection, medications, autoimmune disease, even people that have uremia or elevated the BUN, BUN, or urea, and even cancer or malignancy can cause that. It's a pleuritic chest pain, as I explained to you, that it's getting worse with inhale and exhale. With the breathing, it gets worse. But the patient, when they leaning forward, the pain, it gets better. And this is one of the hallmark of the pericarditis chest pain. But also lung can be a cause of the chest pain. People can get pulmonary embolism, blood clot in the lung, blood circulation. Pneumothorax, which is leaking air into the space between the lung and the chest wall. In the pneumothorax, the building of the air puts a pressure on the lung, prevents the lung from expanding fully when you inhale. Also, pneumonia can cause pleuritic chest pain, the pain that it gets worse with breathing. And in pneumonia, you can have also at the same time fever. The patients can be lethargic and at the same time. Lung cancer, it's less likely cause acute, but when nobody detect that, it can manifest as pneumonia, or it can manifest as the lung mass by itself with the cough and other symptoms. People with asthma or COPD exacerbations also feel chest pain. Mainly they feel chest tightness. They're going to complain to you that I cannot breathe. This is very typical. When you look at the medical history of the patient, you see the patient had asthma, had a COPD, and has the feeling of the chest tightness. This is the time you can say that's probably exacerbation of asthma or COPD, and your intervention should be focus on this treatment. Pleuritis, which is inflammation of the pleura area, cause pleuritic chest pain, also is lung related. But gastrointestinal also can be very common cause of the non-cardiac chest pain. GERD, which is gastroesophageal reflux disease, or we call acid reflux. It's one of the most common cause of the non-cardiac chest pain, and is actually can be very mimic the heart chest pain, angina pectoris. And exactly the patients can describe it as squeezing, burning, locates substernally, and radiated to the back, neck, jaw, or arms. It can last minutes to hours and resolve spontaneously, or even when you give the patients some antacid reliever. It may happen especially after eating, can awakening the patient from sleep, and also can be exacerbated by emotional stress. But never forget, GERD can be one of the most common cause of non-cardiac chest pain. Other cause of chest pain by gastrointestinal issue can be peptic ulcer disease, or in a simple word, stomach ulcer. It's actually happen when the people eat food, provoked by eating food, and also they feel fullness and discomfort in the stomach. Sometimes patients feel very nauseous. Sometimes they have no desire to eat, and this is one of the common cause of the chest pain as well. Some people can get problem with motility of esophageal area, and that is actually happened because the feeling a spasm or a squeezing at the substernal area, especially after when they take foods. Esophagitis is inflammation of esophagus and can be secondary to infection, especially candida or fungal infection, can be sometimes related to medications, and also can be sometimes to radiation. Like people get cancer, they have radiation on that area and they get esophagitis. This is also can be very sharp retrosternal chest pain. Some people have chest pain because they have hiatal hernia. Technically, the upper part of the stomach push through the diaphragm. The muscle can actually separate our chest and abdominal section, and that causes severe acid reflux, and also not only acid, but whatever in the stomach content is back into the esophagus, which actually can cause severe GERD or gastroesophageal reflux disease or severe acid reflux, and can cause this problem. On the other side, if any time when we have any inflammation on our gallbladder or pancreatic area, we also can have chest pain as a symptom. Don't be surprised. Musculoskeletal is one of the most common cause of chest pain as well. And that can be chest wall pain, can be rib pain, can be related to a sternal bone as you see in the picture. Any inflammation on this area can cause pain, especially when you palpate the area, it actually makes it worse. Trauma to the chest also can cause pain. You may also experience many times the psychiatric disorder can cause the chest pain. Panic attack, anxiety attack, somatizations, or even factitious disorder can cause chest pain. Panic attack is actually typically present with spontaneous episodes of intense fear that begins suddenly and actually can last for several minutes to an hour. Actually, 1 in 4 people with panic attack, they can have chest pain and shortness of breath. They can have palpitation, they can feel nauseous, they can have a cold sweat, exactly like somebody with coronary artery disease. Factitious disorder is a serious mental disorder. Can someone wanted to appear sick purposely because want to get attention, or wanted to say that either I have a self-injuries or I'm very sick, and they can pretend that they have a severe chest pain. Anxiety attack at this other time is actually cause chest pain. You may gonna see many times in your years of working as a nurse that people with anxiety attack can have chest pain as well. One of the other causes of chest pain is a referred pain or radiating pain. The pain is actually in other visceral or somatic structure, but radiating to the chest wall. What is the most common? Back pain. Any problem with the spinal area, spinal arthritis, spinal cord issue, that can have a referred pain to the chest wall area. Other cause of that can be inflammation in gallbladder, cholecystitis, or people with inflammation in pancreas, pancreatitis can have a chest pain as well. That's why don't forget, referred pain can be one of the cause of the chest wall pain. But the first thing that we need to do is assessment of the chest pain. And the first step is evaluation, head to toe evaluation. Looking at the resident's mental status. Is he or she the same person that you've seen earlier, but now is more lethargic, more confused? Look and look and look. You can detect many things by just watching the way the resident is breathing, or for example, changing the position. Look to see if it is more of the respiratory issue. You can easily look at the breathing pattern and see, for example, if someone is coughing, wheezing, is it more related to respiratory issue? Maybe this is pneumonia, maybe this is a COPD exacerbation. Know about the resident's history. For example, if somebody has a history of COPD and asthma, recent infection, somebody's immobile, like for example, think about somebody after surgery, probably DVT, moving to the lung, cause the blood clot in the lung circulation or pulmonary embolism. Is this the recent heart procedure? These are the things that is so important. Ask the relevant questions and definitely use your stethoscope. Is one of the best devices that you can use. Listen to the chest. You can actually find many things on the chest. Sometimes you can see, I don't hear any breathing sounds in my stethoscope. You worry about pneumonia, you worry about pneumothorax, you worry about a fluid in the lung, or you may hear a lot of wheezing in the lung, then you know this is more COPD, more pneumonia situations going on. As many times, whenever you have pain, you always ask relevant question. Where is the pain? Show me the location of the pain. Is it on the right side? Is it on the left? Is it on the substernal area? Does it go anywhere else? You won't think about the radiation of the pain. When did it start? Is it something that just happened suddenly? Or no, you had a chest pain since morning and now gradually get worse? How long has it last? The timing is so important. How bad it is? Can you scale the pain for me from 0 to 10? Does anything make it better or worse? That's a very good question, because for example, if somebody says when I lean forward, I feel better. When I inhale and exhale, I feel worse. Then you have pleuritic chest pain. Have you taken any medication in the past to relieve it? That's a good question. Have you had similar chest pain in the past? A lot of time, the patients or residents can help you a lot with the guidance about a chest pain assessment. When it comes to assessment, the first thing is general appearance of the patient. Just look. Is this resident or patient is lethargic or restless? Is it confused or not confused? Comfortable or not in acute distress? This is so important for you to know, because when you do assessment, all this question is so important when you are making a telephone encounter to the providers or on-call providers, because they need to get this information, how these patients look like for you. When you do assessment, you always rely on your eyes. Look at the neck to see if there's any neck vein distension. You look at the chest wall. Do you see any asymmetry on the chest wall? Thinking about pneumothorax. Palpate the chest. If you feel when you palpate on your assessment and the pain get worse, it's more toward musculoskeletal pain. Is this patient stable? That's so important. Also ask the patient to rotate or change the posture. Is the pain get worse when they change the posture? Or for example, when the patient turned left and right, the pain get worse. I feel more pain on my back now. Then you know this is probably more referred pain. You do abdominal palpation. It's so important to see if there's any area of the right side, pancreas or gallbladder is more tender. It's crucial to also check all over the body, part of your assessment. When you see like a 2+, 3+ edema in the lower extremity, at the same time patient has chest pain and shortness of breath, you think about more cardiac related, can be just acute congestive heart failure. This is so important when you look at it. And that's why the assessment of the nursing at the bedside is a crucial part of the chest pain evaluation. No question is, what kind of chest pain do we need to report to the doctor urgently? Any new onset of the chest pain or the chest pain that is happening again but not relieved by nitroglycerin. Some people, they have order of nitroglycerin in the chart, and if you think this is the heart, you give the nitroglycerin and 3 times every 5 minutes, and you see the pain is relieved or not. And if the patient doesn't have, then you don't need to do that. But some of the patient, they have pre-order of nitroglycerin tried. Chest pain that actually associated with symptoms like abnormal vital signs. They have diaphoresis, cold sweating, nausea, vomiting, shortness of breath. That needs to be quickly report to the provider right away. But let's think about some of the cases that you can avoid the transfer. Use acid reflux reducer. The pain is actually much better. You use a topical or oral pain medication. For example, patient had a back pain, radiating pain, or referred pain, and now pain is much better. With the discussion with the on-call provider, you started treatment of pneumonia. You had a case of pneumonia. With the use of bronchodilator, like you have a Duonep, ipratropium, albuterol, you use it every couple hours, you see the wheezing, you see the chest tightness, you get much better. You're providing oxygen for the patient, case of the COPD exacerbation. Some patients may have psychiatry situation, anxiety attack. With the reassurance, with the use of the tranquilizer medications or anti-anxiety medication, patients feel better. These residents don't need to be transferred to the hospital. In conclusion is, many cases of chest pain in nursing home are not cardiac. It can actually be non-cardiac and can be easily assessed and manage at nursing home. But the key is your assessment. Assessment and assessment. You can make a huge change in directing residents from not be transferred to emergency room by your right assessment, getting actual information that you're doing it. And reporting with the right assessment can also help the providers over the phone to make a better judgment. This is one of the biggest problems that we have. Most of the time when we call the providers and we have really no data, we just say, oh, the patient has a chest pain and shortness of breath, it's okay, we'll transfer it to the hospital. But if you come and say, yes, patient has a cough, has a fever, has some shortness of breath, vital signs are stable, you talk about the questions about the chest pain, you talk about other symptoms, more likely pneumonia, we can actually start the treatment antibiotic right away here. We can order the chest x-ray, even come tomorrow, but we already started antibiotic. We can assess the patient, we can continue monitoring the patient and see how the thing's gonna go. And or sometimes patient has a referred pain. I can try some pain medication. I see this more positional patient with the change of posture. The pain is getting worse. This is more referred pain, and you can address that. As many of non-cardiac chest pain is gastrointestinal. Maybe the doctor can you use some antacid medication? Maybe we can use some antacid cocktail to see the chest pain is getting better, patients feel more comfortable. We don't need to transfer many residents to the hospital. Thank you so much for listening. This is one of the most important topics about the chest pain as one of the most common cause of transfer to the hospital. Thank you for being with me today.